So what I wanted to do is just kind of really kind of explain how we think a little bit about PANS. I know what PANS stands for, but I like the acronym that I put here better, which is the post-infectious autoimmune neuropsychiatric disorder, although it's pediatric acute onset by definition. This better explains, I think, what we're dealing with. And, I'm trying to think and usually, what's causing it, what's underlying it. So this is really what's going on. It's an autoimmune neuropsychiatric disorder due to an infection. And then we'll kind of get an idea what that is. Most people know, but we'll just kind of go through that. But then think about the things I mentioned before that we might need to think about. Are they present or not? The number three is something I think I've not heard other doctors deal with, which is looking at the adrenaline systems and how that can be contributing to rage. There's one slide on something called IASO, which we'll get to, which is just really covers, it's enough of a unique thing that I think I needed to put it in as a learning objective of itself. And then I can give you kind of a general idea what we do at Sancta Familia Center for treatment. And then I'll take questions. So next slide, please. So what's different from how I was trained is this idea of a systems biology approach. We're seeing a lot in medicine that people are getting into silos when it comes to the way they're evaluating a patient. And really, we can't get into just one organ system or just one system. We have to think how all the systems interrelate. And so this systems biology approach is really the functional integrative medicine approach. Let's look at genetic factors, things that we've inherited. Epigenetic are things we inherited, but were things that we can potentially modify. So they're effects in the DNA that can be modified. Genetic things, so things hardwired into the DNA can't. Of all things I've learned as I've gone to this more functional integrative medicine approach, gastrointestinal health is about as important as it gets. I mean, it's, for me, the running joke is with psychiatrists today, you lay down on the couch, you're going through psychotherapy. In the future, they're going to be doing, rectal swabs to find out what the microbiome is so that they can determine, how they're doing. So psychotherapy would still be something to do, but now we're going to have to, also eventually evaluate the microbiome. So neurologic, obviously something important for many, but especially in PANS, autoimmune to the immune system. But this idea that the psycho, so the behavior, neuroendocrine, immune system all interrelated is very, very important concept too. Next slide. So just a little bit on biochemistry and behavior. And the brain's really amazing. When you think about it, we always hear about this electricity that's going on, or this electrical activity that's going on in the brain. But actually, no two cells touch. They communicate to one another through chemistry, or what we call neurotransmitters. So although they don't touch, they transmit things through these chemicals. And really, there's only a couple of different signals, one which is positive or negative, fire or don't fire. And it's this really symphony that is making up behavior. So one of the reasons it matters to think about biochemistry is the constituents for all these chemicals come in our diet, and we need to make sure those are in balance. Next slide. So what is behavior? I think the way I think about behavior is it's kind of what's going on right at the moment, but then there's also this temperament. So we have current behavior, which is the output of what's going on in the brain right at the moment. Are we called to action, or are we called to be still? The other is this idea of temperament. What is our long-term behavioral tendencies? Are we rational, irrational, forgiving, unforgiving, the things that I've listed here? Some of this comes into play to trying to evaluate what is the health and balance of the individual. So although we have a person with PANS now who's having certain symptoms, what were they like beforehand? Was there some pre-existing condition in their temperament, their biochemistry, some other of these organ systems that we talked about. So that it tells us that there may be things in addition to PANS we need to address. Next slide. So what is PANS? So, the general thought, and many, unfortunately, a parent has heard that, there's something mentally wrong with their child and thinking that this might be a primary psychiatric disorder. But really, it's molecular mimicry, which means, unfortunately, the antibody made to the infection or the toxin attacks the brain. And in doing so, that we have the specific symptoms that are listed there. So, for people new, potentially, PANDAS was one of the earlier ways we described it. It's really PANS because of strep. But as we've gone on and learned that there's more infections that can trigger PANS, we now have this more generic term PANS. And really, the key thing is in history is seeing this abrupt change, usually with OCD and or anxiety and or anorexia or some disturbance in food intake associated with the things that are listed here: anxiety, rage, depression. And it's amazing how severe behavioral regression can be, and tics too. It's very, very interesting. The key is in this history is this abrupt onset and or that we have this relapsing kind of history associated with illness or some kind of toxic trigger. So some patients we've seen have had PANS so long. I just recently saw somebody who's 18 that probably had onset at age 3. We are not going to necessarily have this clear-cut abrupt onset, like I said about the first patient I'd seen, where the mom goes, "I know the time and place." But if we have this relapsing of pretty specific PANS symptoms, then we can make the diagnosis that by relapse. And then in my mind, I only ever confirm the diagnosis when I see resolution symptoms based on treatment that would treat this, which we'll get to. Next slide. So what is the differential diagnosis? What else could it be? That is really what we're saying is when we do differential diagnosis of PANS. So biochemistry, which we're going to talk about, Lyme, we'll talk about that too, and other tick-borne illnesses. Mycoplasma is commonly not tested for, which is unfortunate in some situations. So of those that don't respond to the traditional antibiotics like ceftonir or amoxicillin, they may have mycoplasma as one of their problems because it doesn't respond to those antibiotics. Mycotoxin illness, that's the newest of the things that we've learned is really problematic for some. Mast cell activation is a syndrome of histamine release, different than the histamine release we see in allergy. And then the thing I talked about before ISO, or immature adrenal systems overreactivity. Allergies, many people will tell you that their kids flare at that time. No question that can be the case. When you have histamine, you have more inflammation, even if it's not an exposure to the triggering infection, can lead to PANS symptoms. So several things to pay attention to. Next slide, please. So what is the biochemistry? And there's a lot to talk about here. So I'm not going to go over all of it, but the biggest is two things here, which is the disordered trace mineral chemistry and Pyrrole chemistry. These are things that I learned at Pfeiffer, and I'm going to present next. But we tend to check for vitamin deficiencies, especially D3. And we especially look for B12 too, because both of those can affect immune function and cognition. Functional hypoglycemia is the way to think about people that have two kind of responses to sugar. One is if they fast too long, then they start getting dizzy, or they can get grumpy, or they can get rageful. Because at first, we might be able to make up for the need for glucose in our blood by taking some of the extra stored stuff in our liver. But when that runs out, we start using adrenaline to pull it out of our muscle. And if people already have adrenaline problems or are adrenaline sensitive, then that can lead to more irritability and rage. The other is people sometimes crash after they eat. So they make too much insulin and then their blood sugar drops to a point that it causes them to have symptoms. So there are ways to deal with that based on the way we eat and some nutrients that can do that too. So that's one of the things we're also listening for. Do they get hangry? You know, because that's an important thing too. Next slide. So I'm just going to kind of go through the different biochemical deficiencies. This is one of the main things we do. And um, we talk about this all the time. We eventually, as we teach people about these biochemical imbalances, they start to see chemistry. That means you can start seeing these specific behavior groups. And you see it in family members too. But zinc deficiency pretty much is everybody on the spectrum. And I find it often. And one of the key things, and I think I put it in another slide, is, you know, when you do testing at the lab, they'll give you a normal lab range. Well, that's 5th to 95th percentile of persons. That doesn't necessarily mean if you're at 5th percentile, that's good enough and optimal. So the optimal ranges for zinc are clearly higher than the low point in the lab. And the difference of being in a more optimal range is significant improvement in many things. And that's what we see in the clinical features. So when I present these to people, I say, you know, look for these things: explosive temper. The bigger thing that I see is usually frequent infections, wound healing. Hypogesia is poor taste of the tongue. So they may have a poor appetite such that when you restore their zinc level, all of a sudden they start eating things that they didn't eat before. I mean, because if you can't taste, everything's like cardboard. So, you're going to when you're zinc deficient and you can't taste, you're going to taste things that are really spicy or really salty or really sugary. And those are things that aren't necessarily as healthy, you know. And then you can see white spots in the fingernails. That's one of the most common things we see. If you look at this on the other side, the metabolic consequences, it affects copper, which is the next thing we'll talk about. GABA helps us be relaxed so that we don't make it as well, then we're a little bit more tense. And it impairs immune function. Next slide. Copper excess is something that we see not as often as zinc deficiency, but you can see it, especially in those that have had kind of hyperactivity energizer bunnies all on the go with temper tantrums. You know, you can see that tinnitus is ringing in the ears. One of the physicians that worked with us at Pfeiffer published and showed that women that had more postpartum depression actually had higher copper levels postpartum. Copper's kind of is needed, don't get me wrong, but in excess, it leads to more inflammation, okay, more oxidative stress. Inflammation is definitely not our friend anytime. Chronically, acutely in injury, sure, but especially in PANS, any pro-inflammatory response can bleed over into PAN symptoms. Next slide. So this is the big one that we really are sorting out when we see a person. Pyrrole disorder, I say it's a functional deficiency in vitamin B6. One of the common things I've heard is people say, well, we had our blood levels and our B6 level is fine. Well, yes, but if we give you more B6 and these symptoms go away, then we know you're functionally deficient, which means you needed more. And so it's very important to recognize this. We see this often, especially in people that are ill. So it confers an intolerance to stress. So any stress, not just emotional, that's why I put biochemical and physical. So you might see this accentuated after trauma. I fell or broke my bone or something, but it leads to fear and anxiety, okay, and mood swings. And the key one here really is misperceptions. So that means we're not perceiving things for what they are. we're misperceiving for what they are. The biggest is, or the biggest few are, I'm not irritable, which is not true. That person that has pyrrole disorder can be very irritable and not be self-aware. And the other is they also have some degree of a little paranoia where they're like, you did that purposely to make me mad. No, we're just all messy, and so this is something that can really confer a little even more volatility in PANS than just PANS itself. So usually it's also associated with zinc deficiency. So this is something where the clinical history becomes so pretty straightforward. We don't really need to test for it very much. We just know it's there. I have this. Used to be a lot more of a hothead until 20 years ago when I started taking my B6 and other vitamins appropriately. And definitely helped calm me over time. Next slide. So the next two are looking at whole blood histamine. And so I had talked about allergy and histamine. Yes, this is the same histamine, but we're gaining a different insight when we see low or high histamine in a person. And we do have persons that are normal histamine too. But the low histamine person tends to have a little bit more generalized anxiety and panic, racing thoughts. And I put under achievement in there because people that are low histamine when they're ill can be more low. They don't tolerate illness as well as people that are high histamine. So let's go next slide. So high histamine kind of is a little bit more of your driven. So both can have ADHD, but this person is more the perfectionistic kind of got to get her done right. So when I talk about asking about these temperaments is high histamine is kind of like your trauma surgeon and low histamine is kind of like Mother Teresa. One's not good or bad. As I say, you don't want, trauma surgeon is your waiter because, you're like, well, what do you mean you don't like it? You ordered it, shut up and eat it, So, it's just knowing whether these are in balance or not. And that's the key thing. So this isn't something that is super essential in PANS, but knowing what the person's tendencies are and how they react out of being out of balance helps us kind of understand in their behaviors, is this something that we need to worry about? And is this something that's describing what we're seeing? Next slide. So Lyme, it's been known as a great imitator, a great masquerader. I listed a number of diagnoses down there that it can trigger. It clearly is a triggering infection in PANS. That's what can make it very important to look for, especially when somebody's not responding. But if we have other history elements, then we know we have to look for it even more. Migratory joint pain is one of the biggest. There's few things where you're going to have pain in this joint and that joint and this joint and that joint without some finding in the joint. They're going to have migratory pain, but you won't see swelling, you won't see redness. There's sometimes you can if you have a severely infected joint, but in reality, most of them have this migratory pain and severe fatigue that just adequate sleep won't help. In kids, the younger you get, the more their symptoms are primarily neurologic, so anxiety and or depression, unusual behaviors, dizziness, those type of things. This fortunately can be screened relatively well with a tool Dr. Horowitz put together called the MSIDS questionnaire. So we use that pretty often. Next slide. So co-infections are things that we say go along with Lyme. Well, it took me a while to really kind of get my mind around Lyme. Most of the time when people have heard about Lyme, they hear about a tick bite, a bullseye rash, and a flu-like syndrome of symptoms. Yes, that does occur, but only 40% get rash. And not all people manifest their symptoms right away. So Lyme can be something that can be indolent or slow growing and show up later. And in that case, when it's not this acute kind of symptom with flu-like things and a rash. It presents more as chronic illness with immune suppression, and that's actually a lot of the times how we see these co-infections is Lyme was the first wave of assault on the immune system, and then it allows these others to take hold. However, these can be primary infections too, and it's important to know um, Bartonella is something that we see, unfortunately, um, relatively frequently. Um, in It's something to reckon with because when I was at the Monroeville conference, they presented data, and I'm sure it's updated, but I don't know it now. But they presented data that 40% of the ticks in Pennsylvania had Bartonella, 32% had Lyme. So we have more Bartonella, and Bartonella can definitely be associated with rage and anxiety and emotional ability. We had a patient that presented at 15 with schizophrenia of 3 years duration that the dad was saying, I really think he might have PANS. His dad was right. He had PANS, but he also had Bartonella. So once we treated his Bartonella, his psychosis resolved. So Easter, I can't remember how many years ago, but Easter, after 2 weeks of antibiotics and a number of other things, he had his first lucid thought in 3 years. He's now normal and he's a gifted intellect. So, Bartonella is something to contend with, babesia too, not something we have to cover a lot right now, but just to know they're there. Next slide. Mycotoxin illness. So I call it the other great masquerader. I think it's actually the greater masquerader because depending on the degree of this illness in the person, how long they've been dealing with it, the more severe it can affect them. And ice pick pains is kind of the real red flag here. Electric shock sensations, ice pick pains, anxiety, depression, brain fog, and it can come and go if you're not necessarily living in a moldy environment, but you have episodic exposure. You may be reasonably well, but then get sick in that moldy environment. So, example of this is a patient that has had longstanding PANS. And was well treated with antibiotics, and then it went to OSU and crashed super bad. And thought was maybe her Lyme that she had pre-existed, but it wasn't getting better. So when I talked to her, I said, "So where'd you go?" Okay, and do you recollect, mold in the dorm? And the answer was yes. And so we tested her for mold, and that was actually her trigger. She went to a very moldy dorm at OSU and became mold toxic. So once she's detoxed, then she was doing better, and then also helped us find out that we needed to take care of her tonsils to keep her PANS from being constantly triggered. Next slide. So mast cell activation syndrome describes the mast cell. The mast cell is the cell that houses histamine in the body. And the normal way that it releases histamine or reacts to allergy is we have the thing we're allergic to, we call it antigen. And then we have an antibody. And those two, when the antibody sees the antigen, it binds the two together. And then the mast cell sees, the mast cell says, allergic reaction, let's make histamine. In the case of mast cell activation syndrome, the mast cell activates itself. And it's like an amoeba. So if you ever remember amoebas from science, they can kind of ooze different places. So this one oozes its extensions of itself, its pseudopods, into the respiratory tree and the GI tree so that it can sense what goes by and be directly triggered. The biggest thing about mast cell is if you have mold or if you have Bartonella, those are the two most common things we see that cause mast cell activation syndrome to be present. And as you can see by all of those different symptoms, it can really muddy the waters of what we're dealing with. So if we have this symptom, these symptoms, I guess I should say, and especially if somebody upon drinking or eating has near or super urgent, immediate is the word I was thinking of, immediate symptoms, then we have to start thinking of different, that mast cell may be a problem, because true allergy would take a while for the food to be ingested, and then the antigen antibody complex to be made and then presented to the mast cell. Where if you have mast cell in your respiratory tree or in your pharynx, you could trigger it right away. Some patients that um, start eating can have chest pain and swollen tongue, or headaches or dizziness, or palpitations, GI pain right away. This is treated by trying to suppress the histamine response while we treat the underlying cause. Next slide. So ISO, this is the thing that really was, I was very thankful to have found. It was recommended to me, or the book, Hope for the Violently Aggressive Child, was recommended to me by somebody in 2012. Don't like the name of the book, but it definitely helps us describe things we see. So what we're describing here is where I said in Pyrrole Disorder, we have these reactive, anxious persons that can be aggressive and rageful. The way I describe how these two interact is why we get upset is usually mostly brain. Okay, so oversensitized, something we don't like, whatever. Okay, I'm going to get mad now. But as soon as we start enacting our frustration or our irritation or our rage, adrenaline or noradrenaline also come into play. And so through, in this case, what happens is somebody gets a stimulus, a little bit of adrenaline, but they overreact. So rather than, oh, I'm a little upset and I just, snap my fingers, I could be a little bit upset, but I end up knocking somebody out, because what I've done is overreacted for my adrenaline. So this occurs in two kind of pictures. Beta rage, which is fight or flight. That's basically someone could be spooked, somebody could be frustrated, and all of a sudden just lash out randomly. Alpha rage is focus fight. It's like the lion getting themselves ready to strike. So they can be really amped up, but waiting for the right moment to have the greatest impact. So in this one, the aggression is, rather than just random, it's more focused. Getting even is one way to think about it. And we treat these with beta or alpha blockers, or medications used for blood pressure. Very safe medications, a heck of a lot safer than some of the ways these might be treated traditionally with high dose antipsychotics and or high dose stimulants or something along those lines to control behavior. And so in treating these, we can dial back, if this is present, we can dial back the aggression with a relatively safe med and wait out the healing of this dysregulation, wait out to the point that you don't need the meds anymore. And we do, and depending on the person, it might be a year or two, or it might be longer. Some it's taken, 5-6 years until they're in their mid 20s or their early 20s, pardon me, so that they're well matured in their response. But this has been a game changer for a lot of the folks in the practice. We see a lot of rage in Bartonella too. So using the medicines here are something that really has helped us in the patients without having to over medicate them, with antipsychotics and the subsequent side effects. The side effects of both the meds for here are slowing down the heart rate too much or affecting the blood pressure. So we watch that very closely and start at a very low dose and work up. Next slide. So of course we have to worry about other things. So I list those too. Was there a pre-existing learning difference? Are there sensory integration disorders? Is sleep apnea a problem? That's really important, and was there some pre-existing diagnosis, ASD, for example, or something else? Next slide. So really, PANS is a clinical diagnosis. So is Lyme. So we hear a lot about, well, have you had, your Lyme test? Well, if you're really sick, your Lyme test may be negative because the test is testing for antibody. And if your immune system isn't working so well, you're not making antibody very well. So a negative test may not be very good in a person that's sick. And in fact, the sicker one is, the less likely you're going to have a positive test. We use a different test than the traditional Lyme test. We look for evidence of DNA of the infection in the urine. So that's a little bit more useful. PANS, the tests haven't yet, the Cunningham panel hasn't yet been said to be diagnostic. It's very helpful. I think it's a very useful test if things are confused. If we're confused about the history and we're wondering, is there evidence of autoimmune pathology? In reality, we rarely need the test because if you take a good history, then you can make the diagnosis by history alone without testing. So testing is, I think, essential in healing, but not in diagnosis. So what is, so in the history is, what is the timeline of events? Have you had abrupt onset of symptoms? Do you have relapsing symptoms? What are the antecedents? So every time they get, sister gets strep, they go off the wall. Okay, well, that's pretty good reason to say that they're being exposed to a trigger, and so these are some of the general ideas of looking at the lifestyle of the individual before and with PANS. Next slide. So what do we do? So really, the first thing we're doing is really looking at what's the triggering infection. Okay, I do have patients that get worse with swimming in chlorine, but they still have a triggering infection. Okay, we do have people that have mold illness. I have yet to have one that only has mold illness without some triggering infection. So I still think that we have to really think about triggering infections. And so antibiotics really have been our mainstay. And I used antibiotics for rheumatic fever, which is a post-infectious autoimmune heart disease. I saw a lot of that in my training. So I know that we can use antibiotics, especially when they're effective, safely for years, because we had patients on them for 10 years when we were doing rheumatic fever, waiting till they aged out of the risk of having more severe heart disease with rheumatic fever. So I'm of the camp that we really need to do a thorough differential diagnosis of infection and then treat it. And next is treat inflammation. And it really, the turmeric or curcuminoids and resolvins, these are both natural supplements, are essential. So there's several different turmeric and curcuminoids we use. I use a lot of Enhansa. I like Tariva and Inflammablocks, and also Cytoquil, the 3 different manufacturers. Resolvins, we've had pretty much one. It's SPM Active by Metagenics. What's unique about the resolvin is it actually induces resolution of inflammation. So anti-inflammatories, curcuminoids, especially what's really interesting is the curcuminoids is they also have anti-autoimmune inflammation, which is specifically what we're dealing with. But between those two things, we can have a pretty strong effect on inflammation. Ibuprofen does too. I didn't put that on there. I should have, but we use ibuprofen mostly in the acute setting and try not to use it long term if we can help it. And then we use steroids too. So we're up in the ante, turmeric, resolvins, those type of things. And then we're doing a steroid burst and sometimes a steroid long taper. Bacterial infections, bacterial triggering infections usually respond pretty well to the antibiotics and these natural agents without having to go to steroids, but sometimes we do. Viruses, on the other hand, those are the ones that definitely are more difficult to treat. They're more inflammatory. And since we don't have very many true antivirals, we can't help the body be debulked of the virus as well. So steroids become a little bit more of a treatment to help calm the body down. And we have some patients that have tapered their steroids over months. we tend to use lower dose steroids than in some of the literature you'll see, especially on the Pandas PPN site. Um, I don't like to use the high dose because it tends to induce more side effects. I would much rather have a lower dose over time and allow the body to reset. And then if we need to, we can go to IVIG. We don't use Rituxan at this. I don't think I'll be able to because that have to be done in the hospital. But IVIG has a place, I think, but we really don't need to use it too much, I think. I mean, we're doing it more now, but we've had really good success. I hadn't used IVIG until starting about 2 years ago because it was just the point that we had to do it. So if you look at PANS in a nutshell, those are really it. Treat the triggering infection, treat the inflammation, you know. And the other is we want to treat the exposure to a triggering infection. One of the things that early on I had to learn is how come the kids that were on antibiotics went to school and had symptoms? Well, it's because the pupil next to them had strep and was breathing it on them. And so that exposure to strep, which they breathed in, they were on antibiotics, didn't cause strep in them, but their immune system saw strep, which is what triggers the antibody, which binds the brain, which causes symptoms. So in some sense, we're not only treating the triggering infection or infections, we're also trying to keep them from being re-exposed to them, because that's the immune trigger that's going to set off their symptoms. So the other things we do, as I said, biochemistry and bowel health, that's just super important. Stress response, this is something that's becoming more clear to me, is the same system that's affected by IASO is the system that's stress is stored in the body. It's one of the autonomic nervous system and the primal brain have a lot of connection. And the primal brain is really one of the places in the adrenergic system, the adrenaline system. And so we need to do things that help the body, brain, nervous system heal from stress. And that's what some of these things do. Sound Health Collection is CDs you can just play that are specific music that help calm the brain. Brain taps, something where you listen to a guided meditation and music. And then the listening program is something that we do a lot. And it's a special headset and special music that's involved with helping develop new pathways in the brain. But by a consequence of what it's doing, it can be very calming to the brain and the nervous system. So especially for the patients that have longer PANS, some people, just have a quick response and some don't. So those that have longer PANS illness, adding in the listening program helps them go to the next level. If we see ISO, we treat it. And then I consider proper adjunctive medications. I mean, there are patients that I have to use antipsychotics on. It's just the way it is. I can't control their behavior, their delusional thinking, or something such that we need to use it. The idea is when we use it, it's an adjunctive medicine to the treatment I said above. I don't necessarily say that the med is our first line agent, but at some point, Zyprexa for some people is a game changer. So are other meds, but that's one that really can make a big difference. And then if we have somebody who's really not doing well, then I treat mycotoxins, and we'll look at those and treat for those too. So anyway, that's a quick, what do we do? In addition to hopefully paying close attention to the parents' needs and the child's needs and trying to help everybody deal with what a burden PANS can be for them. I think the next slide's the last slide.